Back in 2003, my colleagues, Dr. Steve Burkhart and Dr. Craig Morgan, and I put together a three-part series. At that time, trying to understand what happens when you're talking about this kind of motion. We did this in arthroscopy, a three-part series. It turned out to be a pretty good start on our trying to understand what the problem is. It sparked a lot of controversy and a lot of good papers out of that. And then, so Journal of Arthroscopy editors asked us to revisit this, and so we had a consensus conference, and in January of 2013, we put out the Disabled Throwing Shoulder Spectrum of Pathology 10-year update. So what I'm going to talk about here a little bit was covered in much larger detail in that article that is in Journal of Arthroscopy, January 2013. So the reason we call this the disabled throwing shoulder, now this is not just the throwers, these are overhead athletes, but also overhead workers. It's a description, as I mentioned before, that this is the problem the patients in your office about. It's the athlete's dysfunction that they have. It allows you an overview of all these alterations that create this dysfunction, both symptoms and performance. You know, like the guy, well, you didn't hear it, but the guy says, I can't throw the ball, and that's the problem. This allows us a larger viewpoint to understand this problem and a better ability to evaluate and treat. So the things that we have found, the spectrum of pathology in these groups of patients that have something wrong with their shoulder. They have kinetic chain alterations, they have scapular alterations, glenohumeral rotation alterations, and then they have the actual anatomic injury, whether it's the labral injury, biceps, partial rotator cuff, or combination of those problems. And so you cannot take one of these things and deal with it by itself. You have to take this whole group and work with all those components. In the kinetic chain, the alterations most commonly are seen are hip and trunk strength, weakness, and especially hip inflexibility, mainly in the non-dominant hip internal and external rotation tightness. It can be one or the other, but it's most commonly external rotation tightness. In about 30% of these patients, they will have some type of prior leg injury. It may be as much as an ankle sprain or a meniscal injury in the knee. Did you know that the knee bone is connected to the shoulder bone? Really? You've got your iliotibial band to your tensor fascia lata, to your gluteus medius, to your lumbodorsal fascia, to your lower trapezius and lat, and to the scapula to the arm. So anything that affects, and Ann is going to tell us all about this tomorrow, but anything that affects the leg affects the capability of rotation, force development, arm positioning, and rotation. So any of these things exist. You need to, once again, you can, if you want to do it, do a checklist. Okay, painful throwing shoulder, hip, internal and external rotation, prior history. I mean, just check them off, because in a surprisingly large percentage of the time, you're going to find these present. About 50% of the cases will show some type. So if you have not seen it, it doesn't mean it's seen you. Glenohumeral rotation alterations. We had a very good, Rod talked this today, that it's more than just an internal rotation deficit. It's an alteration in total range of motion that you can measure. It turns out that the largest component of that in most instances, and the biomechanically important part, is internal rotation as well as the external rotation. Mr. Kevin Wilk, physical therapist, and working with our group and Dr. Tim Moole, came up with this concept of what we call posterior shoulder tightness. And it's measured rotation of an asymmetry in internal rotation of greater than 18 degrees and a measured asymmetry of total range of motion of more than 5 degrees. I'm pretty sure that the total range of motion is very, very sensitive. It's dialed in. You lose much of that and you really change, you alter the kinematics. And this combination, this posterior shoulder tightness, is predictive of injury in baseball players. And over 90% of the cases will have some type of alteration of glenohumeral rotation. Why does it occur? Well, like we said, some of it is capsular contracture, but if you really look at it seriously, very few have really, really tight capsular contractures. The model of altering rotation in the cadaver was capsular plication, but I think this more, we see a dynamic component to this that's not due to the capsule. I think it's probably more of a muscular stiffness, which is what's called thixotropy. It's a biomechanical stiffness. It's a property of viscoelastic structures. And obviously, as we talked about before, the bony's fixed beyond the age of 16 or maturity. But why does it affect the 20 or 30-year-old? Because it decreases the margin of error, as Rod showed. The more external rotation you have, the less likelihood you are to have the problem of the shoulder labral tear later on. So it decreases the margin of safety that you need to have for this capability of internal rotation for not only the shoulder but also for the elbow. So how are you going to do this? Well, first of all, you got to measure it accurately, reproducibly. You have to do it off a stabilized scapula, because I can get you anything I want to off if my shoulder blade's moving, but you have to stabilize it. The other thing is, remember that this is a dynamic number, and I'll show you what I mean, a cold number versus a warm number. It will vary depending on when the patient or the athlete last did this overhead throwing motion. And so we actually use this as a curve of measurements, and we track it during the season. I think that's going to be the major thing that we find. This is what we've, so far we've collected, we're up to about 150 professional baseball players, and you can see that if you start here at time 0, which is immediately before a throwing episode, then you measure immediately post-op. You take them right off the field after they've thrown, and you measure, you see you're already down 7%, just from immediately before to immediately after. There's something about the throwing that changes this. However, look at this, 24 hours later, they're still down in internal rotation. External rotation has not changed much at all. Internal rotation is still going down, and it stays down. Now, this is in baseball, Major League Baseball, this is when they throw the next time. See, it drops off again. Now, this curve is exactly what thixotropic behavior does. It maximizes at about 14 to 24 hours. So this very definitely is the fact that it's dynamic, the fact that it relates to thixotropic shows you that there's a muscular component to this that needs to be dealt with in a eccentric strengthening program, for example, as well as the capsular stretching component. So you measure it. You have to stabilize this two-person measurement. You have to stabilize the acromion and coracoid by one person, and then you rotate to what we call tightness. It just goes to where it's tight, right there. You don't take it just to tightness. No scapular movement, no forcing, and the reliability is quite good. You put your arm in the plane of the scapula by putting this little bridge here, and then you just stabilize them here. So we will have the one hand stabilizing, one hand to tightness, and then there's your measurement, and we use a bubble goniometer. You just take it to that position and stabilize. Obviously, you have to look at all the things inside the joint. The labral, rotator cuff, biceps, those are the most common anatomic alterations. And this is not, I've got a painful shoulder and therefore it must be a labral injury. Let's go scope it and find out. No, it has to be a positive diagnosis based on your history of the correct timing. It has to hurt back in here, because this is where you get your peel back and where you get your posterior movement. It's got to be from here to this position right through here. It has to be a pinching, catching. It has to be some type of a sliding mechanism, because you're getting this translation. The dead arm is what a lot of the throwers will talk about, and the definition of a dead arm is one that's not live. And by live, I mean, they know what live is. They can throw. They can get some movement on the ball. The workers can pull and whatnot. It's a dead arm. It just doesn't work well. And the reason it doesn't work well is because you've lost that connective link of the funnel of the shoulder. So it's the history exam, then imaging, as was mentioned earlier. And then if you wait until you scope the patient and try to decide whether they have a labral injury or not, you're not going to get it right, because there's a whole lot of variation in there. If you don't know what goes along with that finding, then you're going to treat this wrong. There's two things the labrum does. I always ask anybody who operates on the labrum, I don't think you should operate on the labrum if you know what the labral roles are. Does everybody know what the labrum does in the shoulder? What does the labrum do? It's much more than an attachment site for the biceps, I promise you. It's not, the superior labrum is not a bumper. It's a meniscus thing, okay? It's not a bumper, okay? Anyway, so two things it does. It facilitates this concavity compression. It's a deformable, slightly deformable structure that has some compliance that allows a good fit and allows concavity compression. So it is what Dr. V'ger called a washer. You know, a washer is a structure between two compressible surfaces that provides stability and even pressure across a compression area. And the peel back is a position in which that washer function is not working well. And so when you do your testing, one of the positions you get it in is this external rotation. You put the pressure on the posterior, you do the peel back, and you see the effect of the biceps. So that's one thing, the labral roll. So this is this washer phenomenon right here, where, you know, in this model right here, the screw is the compression mechanism. Here, the rotator cuff and the coactivation of the muscles provides the compression around this washer. The second thing is that, as I mentioned, Dr. Greg Bain looked at a very good and anatomical study and showed that there's a tension band component to this. And therefore, that's why the O'Brien's test is positive. The O'Brien's does not peel back. What's the O'Brien's do? Has tension on that whole posterior structure going around the corner. And so the anterior slide, O'Brien's, and actually the lift-off test, and I know Burkhart likes the speeds test for the biceps. What are they doing? They're putting this tension band under stress. And the pain has to be back here in the back, not in the front, but the pain in the back. So any kind of anterior tension with the speeds or whatever, the O'Brien's, the anterior slide. But I'll show you in a minute that there's a significant number of patients who will have a positive lift-off, but they don't hurt in the front where the subscap is. They hurt posteriorly where the labrum is because you're putting this tension on this tension band that's not working well. There is a physical exam test that is a level 1 study. It has a very high reliability, and it has a predictive value in the 0.9 range, has a likelihood ratio of 31. For some reason, it doesn't get very much mention when you're talking about labral exam because maybe they think it's not worth. But anyway, if you do this test correctly, this modified DLS, it's very, very clinically useful. It's described in AJSM 2009. Dr. O'Driscoll from Mayo Clinic first described it to me. I modified it in terms of the patient position. You put the arm in 110 degrees of abduction, 90 degrees of external rotation in the plane of the body, and then you move it into the plane of the scapula, and then your downward motion. What you're doing is you're peeling back, you're testing that washer component, putting the biceps on stress in this position, and then you're doing this internal impingement, and then you shear it as you move. And the reproduction of symptoms posteriorly, it sometimes even hurts to get in that position, but certainly with the shear is a positive test. It has a positive predictive value of 0.97, likelihood ratio of 31. This is how you do it. Put the arm up in the overhead position. You can feel right on the posterior, right under the acromion, right there, it comes straight down. That's a positive test. It hurts right there. They'll tell you it hurts right on that backside, anywhere from the acromion down. It'll hurt right on this very back corner right there. That's a positive test. The numbers, these are the numbers. Anything that's 0.75 or higher is supposed to be clinically useful. So it has specificity, accuracy, positive predictive value, negative predictive value, all those things. Compared to anterior slide and O'Brien's, is a much higher test. I would recommend it to you. If somebody has a positive DLS, then you see in the side, you see this labrum not looking right. Those are the ones you fix. If you have a negative DLS, I don't care what it looks like, because you get a 40-year-old. He's got rotator cuff problems, got pain, or you're scoping him, and you look at this labrum. What do? Oh, I'm going to do a biceps tenodesis. Well, in certain circumstances, if those guys have this DLS, whatever you do with the biceps, you have to fix the labrum for this washer effect, not because of the bicep effect, but because of the washer effect. And there's a lot of patients running around here who've had biceps tenodesis who still have shoulder pain. And the reason for that is the labral component of this washer has not been taken care of. In that situation, you've got to repair that. So here's a young guy, and we'll look and see what's going on with him with his physical exam. He's a disabled throwing shoulder. You watch his one leg stability. See how he loses control on that side, but as he comes down, once again, there's a rotational component. He can't stand on one leg. He has a scapular dyskinesis. He has what's called a sixth scapula sitting down a little bit. You don't see, bring it up this way. Right. There's his scapular dyskinesis. You see the type 1 pattern where it's a very prominent inferior medial border. That hurts him. If you stabilize the scapula, do these retraction. I'm going to show you this tomorrow for sure. I'll go over a little bit more. This is called a low row test. We're actually testing competency of the, you see how he tilted his shoulder up, is protracted, and he hurts on the back side. See, I was putting tension on the front side, and he hurt on the back side. He has a scapular dyskinesia. You see the protraction issue right here with the scapular dyskinesia. This is called a scapular assist test. So this guy had impingement, but now I can do this. He doesn't have any impingement. So that's why impingement is not always a diagnosis. It's a sign of something wrong. But in this situation, it's because the scapula is not moving correctly. Once again, you bring his arm in here, and see, there's that. See, internal rotation. And you stabilize the scapula here, and you can measure internal rotation just grossly. It's got to be about 10 degrees of internal rotation on that side. And this is the effect of, see, the effect of tightness on the posterior side. And he'll hurt, once again, back on that back side. You test him here, he's got a certain amount of weakness of his rotator cuff, but he hurts on the back. Now, if you pull it back this way, stabilize the scapula, called a scapular retraction test, you find he has normal rotator cuff strength. Absolutely normal. There's nothing wrong with his rotator cuff. The problem is he's off an unstable base. You bring him across this way right here in horizontal adduction. As was mentioned before, that puts a lot more pressure on a lot of those structures on the back side back there. Now, if you do it that way right there, you find that he's not nearly, he's got a, and then you bring him across this way. That was the O'Brien's that was positive. This is called the Whipple test. Now here's your DLS, positive right there, right where my thumb is. It hurts right in through there. If you stabilize the scapula, get his glenoid out of the way, you find the DLS test is negative. You change that internal impingement because you changed the position of the glenoid. So he's not having that internal impingement. He's weak. He's a little bit weak in abduction, external rotation. This is what I'm talking about. Here's the anterior slide. It's positive. He hurts on the back side of the shoulder, right there. And then here's your lift off. Watch this. Right there. Once again, there's that tension component. So now you know both the tension component and the washer component of the labral injury. Thank you very much.